Welcome everybody to this annual scientific meeting organized by Asia Heart and Vascular Center, usually known as AHVC for short and simplicity. So unfortunately, we can't gather around a nice restaurant, eat food and listen to some educational talk. Instead, we are resorting to this webinar. And I think by now, a lot of people are feeling a little bit webinar fatigue. But I welcome those of you who have decided to join us in this meeting. So earlier we have a talk on cardiology. Currently, we have Dr. Stanley Chia who will be talking about interventional cardiology. Dr. Stanley Chia graduated from Edinburgh, so he's a foreign talent. And after that, he got his advanced training in National Heart Center. And again, he went away to Harvard, Harvard Medical School for his advanced HMDP training in interventional cardiology. So he's a foreign talent twice. So right now he has been in private practice for the last 10 years. And he's expert in doing complex intervention, that means multi-vessel disease, heavily calcified disease, and chronic total occlusion. So without taking up his time, we shall now have Dr. Chia to start his talk.
All right. Thank you very much, Dr. Tan. Just let me share my screen. Okay. Now, just let me do some housekeeping. Sorry, just to fix this. Sorry about that. Okay. All right. Okay. Now, thank you once again for joining us on this lovely afternoon, and hopefully everyone is keeping healthy and safe. Now, in the next 30 minutes, I would just like to share with you some of my thoughts and some of the latest evidence on percutaneous coronary interventions versus coronary artery bypass grafting surgery. I think the key thing we want to talk about today is how can we help our patients choose? And I think this may be a very pertinent issue for a lot of us because so often, maybe in cardiology or in family practice or even other specialty, we get our friends, we get our relatives who come and ask me, I've been advised to go for bypass or PCI. Now, how do we choose between these two very different modalities? Now, we all know cardiovascular disease is the leading cause of death in the world. And in Singapore, it is the second commonest cause of death and hospitalization. And of which, of all the cardiovascular disease, coronary artery disease alone account for 80% of all these cases. Well, coronary artery disease causes angina pectoris, myocardial infarction, and ischemic heart failure. And these two are the main mechanism which eventually can lead to cardiac death. And coronary artery disease is characterized by the development of atherosclerotic plaques inside our coronary arteries, as you can see here. These plaques can lead to a stenosis of this vessel, and if they are flow limiting, they cause ischemia. And sometimes these plaques become unstable, they rupture, and this can result in thrombotic vessel occlusion, leading to acute myocardial infarction. And both myocardial infarction and ischemic heart failure can ultimately lead to the patient's demise. Now, so how do we deal with coronary artery disease? The main aim for treatment is to alleviate anginal symptoms and to prevent myocardial infarction and premature death. The treatment can be divided mainly into two ways. One, medical therapy, of which we try to use various medications to reduce angina, as well as to reduce or reverse plaque progression. As for invasive strategies, we essentially have two modalities, and their aim is to re-establish blood flow to the undersupplied myocardium. And these two modalities are the ones that we are all familiar with, which is percutaneous coronary intervention, PCI, or coronary artery bypass grafting surgery, or known as CABG. Although they both have the same aim, just to re-establish and restore blood flow to our hearts, they are very, very different procedures. Just to remind ourselves what PCI is. PCI is a procedure that is done under local anesthetic with the patient fully awake. The doctors will put a small tube just either from the wrist or from the groin, and this tube will just travel along the blood vessel while the patient is fully awake all the way to the heart. And we'll use a balloon, as you can see here on the left panel, to stretch open the blockage, the flow-limiting clot. Thereafter, we implant a stent, which is essentially a metal scaffolding or wire mesh, just to prop up the blood vessel to restore the blood flow. Here is an example where you can see on this panel, there's a tight narrowing in the middle of the right coronary artery, leading to severe symptoms for this patient. So in a procedure that usually lasts about 20 minutes, a stent is inserted, and thereafter in the same segment, you have a metal stent propping up the artery. Blood is restored to the myocardium, and usually the symptoms are quite rapidly relieved. As for coronary artery bypass grafting surgery, this will be an open heart surgery. Basically, it's true that there will be a sternal wound, and basically the surgeon will be able to access the heart. Thereafter, you'll take grafts or conduits harvested either from the leg, the saphenous vein, or the left arm, usually the radial artery, or they may use an internal memory artery, usually from the left chest. They will suture it beyond the point of obstruction in the coronary arteries. So blood can be diverted from the main aorta beyond the coronary blockages to the downstream artery. Thereafter, blood flow can be delivered to the heart, and hopefully the symptoms will be relieved. So these are the two treatments, PCI and CABG. So what are the real difference in terms of data and procedure? Again, just some refresher. This is a coronary tree. All of us usually have two arteries, one on the left, one on the right. So you have the left LAD, left anterior descending artery, and left circumflex on the left, which are two major branches, and the right coronary artery. So for terminology, when we talk about disease, we have single vessel disease where there's a major obstruction in the big, large epicardial artery. So it involves one artery, it will be single vessel. If it's two artery, it's double vessel disease. Let's say you can see here when all three blood vessels have significant flow-limiting obstruction, it will be triple vessel disease. When we talk about left main is a portion right near the front of the heart, as you can see here. And because it supplies a huge area of myocardium, it becomes a very significant territory. So if you have left main and all three blood vessels disease, this is considered the most severe coronary disease. So there's general consensus among both cardiologists as well as cardiac surgeons that if you do have single or double vessel coronary artery disease, generally PCI is the preferred option because it's simpler, it's lower risk in terms of procedure. If you have acute ST segment elevation myocardial infarction, when time is the essence, where you want to rapidly restore the blood flow, again, PCI would be a preferred option. For non-ST segment elevation myocardial infarction patients with ongoing cardiogenic shock or ischemia, then again, where time is the essence, perhaps PCI may be the fastest way in most cases just to restore the blood flow, at least acutely. And for patients who are surgically unfit or at very, very high risk of other comorbid conditions, again, PCI may be considered a better option. All this can be based on the fact that if you treat patients medically on this graph, if looking at the different kind of disease, looking below, you have one single vessel, two vessel disease, all the way to triple vessel disease. Again, the less vessels that are affected, your annual mortality with medical therapy will be lower. However, if you have significant three vessel disease, obviously your mortality will be higher just on medical therapy. Hence, the higher the mortality, it justifies a higher risk approach, perhaps a bypass or very multi-vessel PCI in order to improved life expectancy. Again, for surgery, there is general consensus that if patients have triple vessel disease and they are diabetic with diffuse disease and poor left ventricular function, bypass is a preferred option. Based on the FREEDOM trial that was published almost 8 years ago, this is a huge multi-center trial to investigate the strategies for multivessel revascularization in patients with diabetes. As you can see here, the primary outcome is composed of death, myocardial infarction, and stroke. And clearly, at the end of 5 years, you can see that the event rate is much higher in the PCI group compared to bypass. Similarly, the all-cause death separates in the right panel here, where you can see the numerical number of deaths in PCI is greater than bypass. Therefore, CABG was accepted to be superior to PCI in that it can significantly reduce both rates of death and MI, although with a slightly higher rate of stroke, usually about 2% compared to 1%, at least in the first year or two. So apart from those groups, what about other patients with triple vessel disease or left main disease? And here lies the controversy. There are various differing opinions about how to deal with these patients. And over the last 10, 15 years, there's a plethora of trials, reviews, commentaries, multi-center trials comparing PCI versus CABG in all these patients with multivessel disease. And from all these trials, basically, they do come down to some simple conclusions. Firstly, both CABG and PCI are very effective in reducing angina and improving the quality of life, certainly compared to medical therapy alone. And PCI, especially in stable coronary artery disease, did not appear to reduce mortality or prevent new myocardial infarction. Bypass has been shown to improve survival and reduce new myocardial infarction compared to PCI. However, this is not always detectable in all the trials, and it also appears dependent also on diabetic status and the extent and the severity of coronary artery disease. Again, just to explain again some common misconceptions for patients. Lots of people always think that, let's say, if I have a tight narrowing, 70% narrowing, I'm going to get a heart attack. Well, looking at this graph in panel A, you can see that based on the lesions below, let's say from no lesions to, let's say, 81 to 95% severity, the more severe existing narrowing is, then the more likely this is to progress to complete occlusion at 5 years. So it is true, if a patient has 70% narrowing, it's more likely to progress to 100% in 5 years compared to a narrowing that's about 20%. And secondly, in the middle panel here, again, if you have a narrowing, pre-existing narrowing, let's say 90%, it's more likely to progress to a myocardial infarction compared to a stenosis that's 25%. However, because there are far less obstructive plaques in our body compared to the number of severe deaths, there are far less severe stenosis in our plaques in our body compared to those less obstructive plaques. Commonly, we find that MI do present frequently by plaques with previous stenosis that are less severe. Therefore, it doesn't mean that a patient with a heart attack always had a pre-existing 70%, 90% stenosis. It may equally occur from a 30% narrowing. And because of that understanding, when we try to determine the differences between PCI and bypass in terms of preventing death, is the way that we go about doing the procedure. Usually for any procedure, we try to relieve the flow-limiting obstruction. So for PCI, we stent the flow-limiting lesions, as you can see here on the left panel, but there may be non-flow limiting lesions downstream or upstream that may lead to thrombotic occlusion in a few years' time. In coronary bypass, the concept is different. Basically, you just put a graft beyond the blockage. So irrespective of whether there's flow-limiting lesions upstream or non-flow-limiting lesions that may even occlude subsequently, basically blood flow has been restored to the distal segment. Therefore, even if you have a new occlusion, it does not matter. Now, coming back to the topic of triple vessel coronary artery disease. The landmark Syntax trial was published almost 8 years ago. Basically, this trial compared PCI using the first generation drug-eluting stent versus coronary artery bypass grafting in patients with left main and triple vessel disease. This is a multi-center trial carried out in North American and European countries and included 1,800 patients that were more or less equally randomized to both PCI and CABG. Before we go to results, it is just to highlight that they also came out with the concept of the severity of the disease. They came out with a Syntax score. So in essence, if you have a low Syntax score, it means that the disease are not so complex. Maybe they are discrete, they are not diffused, they are less likely to be obstructed. Whereas if you have a high Syntax score, it means that you have very complex disease. So looking at a 10-year extended result, actually after 10 years, the mortality, well, is marginally or numerically higher in the PCI group compared to CABG, but this does not reach statistical significance. We look at it, it's an absolute difference of about 3 to 4% after 10 years. So a difference of about 0.4% a year. Specifically for the triple vessel disease group, there is a slightly higher difference. So there's 29% of mortality in the PCI group compared to 21% in CABG group. Again, there are mortality in both groups. So the absolute difference is about 7%. If you look at it another way, it also means that in order to prevent one death, one mortality in triple vessel disease, you will have to have number needed to treat is 14 bypasses. If we want to dissect the data even more, again, we have patients with high Syntax, the most complex disease. And here you can certainly see that the cumulative event rate for the PCI group is much higher compared to those who undergo CABG. But at the intermediate score, you can see that the curves, the separation narrows. And again, in the lowest risk group, again, the differences is much less. And just to highlight, again, the differences is driven mainly by the need for repeat revascularization. So in other words, for triple vessel disease group, there's no specific difference between death, myocardial infarction, or MI, but most of the numerical differences are driven by the need for repeat revascularization. As a follow-up to that trial, there was another trial performed in South Korea. Again, this is a multi-centered trial, although they intended to recruit 1,700 patients. Ultimately, I think the trial was stopped because of slow recruitment, but there were still 880 patients in this trial with multi-vessel disease, and they underwent PCI with contemporary drug-eluting stents versus CABG. They look at the primary endpoint of composite death, MI, or target vessel revascularization. And this group are lower risk with an average Syntax score of about 24. Again, for the primary endpoint in panel A, you can see there is a separation in terms of PCI and CABG, with CABG definitely better compared to PCI. So primary endpoint at 2 years is 11% for PCI and CABG at 7.9%. And by 4 years, there's a 5% absolute difference in terms of the endpoint. However, if you look at the individual endpoints, what is the composition? There's actually no significant difference in terms of death, stroke, and MI. So numerically, they are not very different. And again, most of the difference for this trial is driven by the need for repeat revascularization, almost twice, double that in patients who undergo PCI. So perhaps a different perspective is to see them as in triple vessel disease. Patients certainly with less complex disease, basically like a syntax score of less than 22 or average score of 24 or 25 in the BEST trial, the outcome differences were confined predominantly to the repeat revascularization endpoint. So if you look at the BEST trial, any revascularization is 11% versus 5.4%. And you can say, this is a huge difference. It's a 51% relative risk reduction. But actually, if you look at it another way, 89% of patients did not need repeat revascularization, and 94% of patients who underwent bypass did not need repeat treatment. So again, the number needed to prevent one revascularization in this group of patients is 18. So you can say that perhaps you need 18 bypasses to prevent one repeat PCI. So is that a big difference for a patient, or is it worthwhile risk? Then we also move on to left main coronary artery disease. Again, using the same syntax score in the syntax trial. Again, looking at patients with very complex disease with a high syntax score, you can clearly see that bypass is certainly much better compared to PCI in terms of all the endpoints. But once you have intermediate or less complex disease, or even low syntax score, then you can find that there's actually no significant separation between the two graphs. So there was, although this was not the primary intention of the study, it did raise the question that perhaps patients at lower risk, they may benefit just as much from PCI compared to CABG. Again, at 10 years, looking at this subgroup, in terms of mortality difference, there was no significant difference. So you're equally likely to live or die at the end of 10 years, whichever treatment you choose. Subsequently, there was an Excel study which actually specifically tried to address this issue. So they took patients with left main coronary artery disease at low or intermediate anatomical complexity, and they randomized them to either bypass or PCI of the left main. Again, you look at this graph. In terms of the outcomes of death, stroke, and myocardial infarction, again, there was no statistical difference between the two. So there's a higher risk of a bad outcome for CABG in the first 1 to 2 years because of a higher surgical risk, but thereafter, there may be a slight late catch-up of PCI at 5 years. But overall, there's no statistical significant difference between the two in terms of death, stroke, or MI. Again, if we enlarge the graph, even if you look at a numerical the absolute difference, perhaps a 3% difference point, if you look at the number needed to treat to prevent one death, stroke, or MI, it would be roughly about 37 bypasses to prevent one death or stroke or MI. If you have read the news, there was a lot of controversy in terms of people making claim that perhaps the Excel study investigators were withholding some mortality data, and subsequent the surgeons came out to reject, at least the co-authors who were surgeons came out to reject the study findings. And they even withdrew their support for the heart disease advice that was released by European Society of Cardiology in recommending PCI for left main as an acceptable option. We're going to go into the absolute mortality data. The subsequent meta-analysis of all the major trials looking at these left main disease, as you can see here, Excel does stand a little bit to the right of this curve where there's a slightly higher all-cause death compared to all the other trials that address the questions such as Noble, Syntax, and pre-combat trial. If you look more specifically at just cardiac death, actually, there's no statistical difference between the two. And the main difference, again, is always driven by the need for repeat revascularization. In other words, if you go for PCI, it's more likely for you to need a further procedure later on. So, of all these data and probably information overload, how do we make sense of all this, of all these data? Ultimately, I think we still have to ask ourselves, what do our patients actually want? Are the statistically significant difference in clinical trials meaningful at all to our individual patients? And what's the difference between absolute risk, relative risk, and number needed to treat? Well, the key points that we want to take from this is firstly, for left main and triple vessel disease, actually nowadays, technical success can be achieved in almost more than 90% in all cases by either PCI or CABG. Perhaps the risk of death and MI after PCI or CABG are similar, although some studies may state slightly higher rates after PCI. But we do recognize that the risk of stroke will be higher after CABG. And the requirement for repeat revascularization is definitely higher after PCI. So like all things, it's down to weighing the risk and benefit. So what do I tell my patients? Firstly, for PCI, there's a lower upfront risk, 1 to 2% in the short term, compared to bypass, which has a higher upfront risk of usually about 5% of heart attack, stroke, or death. But if you go for PCI, the need for repeat procedure in the first 5 years would be as high as 15 to 25%. If you go for a CABG, there will still be a potential need for repeat procedure. It's just that it's relatively lower, let's say 5 to 15%. At 10 years, the overall mortality rate will not be significantly different between the two. And for PCI, the spontaneous risk of MI might be slightly higher, and the risk of stroke might be slightly higher with bypass. And on more practical issues for our patients, PCI is done by local anesthetic. CABG is general anesthetic. The wound for PCI is usually a 2 millimeter needle puncture in the wrist. Bypass is a sternal wound. For PCI, you stay in hospital for 1 to 2 nights. For bypass, on average, it's about 5 to 7 days. To return to normal activity, it takes about, let's say, 5 to 7 days for PCI, and usually anything from 4 to 8 weeks of recovery for bypass. The cost, at least in a private setting in Singapore, is largely similar depending on the number of vessels that's affected. And you can get symptom relief relatively fast with PCI, usually within a week. In CABG, the flow-limiting stenosis would have been addressed. But again, symptom relief will depend on the healing of the surgical wound. So for myself, who do I send for surgery? Those with very complex disease with triple vessel and left main disease would probably benefit more from bypass. Those with intermediate syntax score with triple vessel disease, I will probably still consider PCI first. Of course, if they have insulin-dependent diabetes, then I may be more inclined towards bypass. Again, patients who are not tolerant of dual antiplatelet therapy, or they have chronic total occlusion with large important territory at risk, they are not amenable for PCI, or they have failed PCI, surgery may be a better option. Or again, if they have several restenosis, or if they are poor PCI candidates with excessive anatomical proximal tortuosity and they are calcified vessels, then PCI would be better. So what do I tell my patients? Well, if you have diffuse triple vessel disease, diabetes, and poor heart function, bypass is probably the best option. Otherwise, consider what is important to you individually. If you want to be free from any kind of procedures for the first 5 to 10 years, then bypass may give you a better chance of this. You also have a slightly higher chance of living longer, although the absolute numbers would be maybe 4 to 8% chance over 10 years with bypass. It is important for you to return back to normal activity as soon as possible. PCI trumps CABG. If you are worried about the size of the wound and discomfort from the wound, of course, PCI would have a smaller wound. And the risk of spontaneous MI is marginally higher with PCI, but the risk of stroke is also marginally higher with CABG. So ultimately, well, a heart team discussion may be helpful that involves a surgeon, physician, interventional cardiologist, but it will essentially come down to the preference of your patient, what the individual's belief and philosophy, and also, more importantly, the patient's confidence in his or her doctor, may it be the surgeon or cardiologist. Well, thank you very much for your attention, and happy to take any questions.
Okay, thank you, Stanley. I think that's a very, very nice summary. Although it's quite a lot of data, but I think that's necessary to share data with all our GP partners. So, Dr. Tan, you are the other interventional cardiologist in our group. Any questions you want to raise or anything you want to comment?
Yes, okay. So Stanley, you see, very often when talking to a surgeon, they would tell the patient, hey, look, when you do stenting, you're going to end up repeating the procedure at some stage. Whereas if you go for bypass, it's a once and for all procedure. So the question is, number one, is that really true? Is it a once and for all procedure? And if I have a youngish person, like say 50 years old, he's got multi-vessel disease, and you said that there may be a survival benefit. So does that mean that if he goes for bypass, he becomes a normal person? He no longer need to worry about his arteries anymore, right? So those are the two questions or two issues that commonly come out. A, is it a once and for all? B, if you are young, you go for bypass, you may be able to live longer, but doesn't mean that your problems are all solved.
I think, yes, I certainly agree with you that we actually get a lot of these comments from our patients, which is better. And it is difficult. And essentially which is why I structured my presentation this way. I did not say that which is better, which is worse. They both have their benefits, but in terms of the absolute data, if you go for bypass, yes, your chance of needing repeat revascularization is lower. It doesn't mean that you won't need that. As I said, in 5 years, data will show you about 15% of them, or even 20% of them, will need a repeat procedure, and maybe a PCI or stent. And we have lots of patients with bypass that we have to repeat stent and repeat procedures, mainly because for the grafts, it's well recognized that, for example, the vein grafts, within a year, 20 to 30% of the vein grafts will occlude. It's just that the patients may not have the symptoms for it if you don't look for it, or you don't do a scan to look for it, but they may occlude. And if there's still ischemia, you may need a repeat procedure. Of course, PCI, the chance of needing a repeat procedure is higher. So it's just comparing the two. But it's certainly a fallacy to say that you go for bypass and you will never need a procedure. I'll say on data, probably 10%, 15% will need a procedure again within 5 years. So it all comes down to what is important for the patient. Will they want to have a symptom-free period, or do they want to pay once off and hopefully they bet that they won't need a second procedure? That will be down to what they believe in.
Okay. So one of my experience, I don't know about you, is that sometimes the people who go for bypass, they're young. They go for bypass around 50 plus years old. Now they show up about 70 something years old with symptom. And when we study the arteries, the grafts are occluded. That's okay, but the problem is that the native arteries are also totally occluded. And I find that it is very difficult to do anything for them. Right? Have you had experience like that? And what would you do for them?
Yeah. So again, as I explained, I have shown earlier on, the mechanism for PCI and stent and bypass is different. For PCI, you fix the worst point. Then subsequently, you have a lot of other minor narrowings that may progress. And once they progress, you find symptoms, you find problems, and you go ahead and put in a stent before they occlude. For bypass, because we put the grafts beyond the blockage, so everything upstream will be expected to progressively block off. And so for these patients, it is well and good if the grafts remain patent, and then they will have a good, long, happy life. But once the grafts blocked off, then it becomes very, very difficult for both the cardiologists and cardiac surgeons to deal with, mainly because, as Dr. Tan has mentioned, you have this long segment of completely occluded artery, and then technically it becomes very, very difficult, and you may not be left with a lot of good options thereafter. But again, because we can't predict which are the grafts that will occlude, which are the patients who will progress, so it's also difficult for us to say all patients should go for PCI rather than bypass, or the other way, all patients go for bypass, because downstream, down the road, we do expect problems to arise from both groups of patients.
Okay, Stanley, I think that's very, very nice a way to summarize. I got some questions here from the attendees. So one of the questions is that if the patient has a previous stroke and recovered from a stroke, is it logical or more advisable to ask the patient to go for PCI, given that it's a left main disease? Or ask the patient to still go and see our surgeon and tell them, hey, let's see what the surgeon says about your stroke risk. This is for someone in particular who has recovered from a stroke.
Okay. Again, if someone has stroke, also we want to want to work them out very carefully. Why did they have a stroke? Is it, okay, there's a hemorrhagic stroke? If you have hemorrhagic stroke, then you also wonder whether you want to give them strong antiplatelets and heparin before the procedure. Now, if it's a occlusive stroke, then if there still pre-existing narrowing, let's say 60-70% carotid artery stenosis, then you do know that if you go for a major bypass, you go on the bypass machine, the risk of triggering a stroke will be higher. So considering a PCI may be a slightly better option in this group of patients. But again, this is probably a decision that we will have to discuss carefully with our neurologist to see which has a slightly perioperative risk. I think I saw a question also on left main for bypass. Is it the same patient? Is it?
No, I think it's not the same patient, but it's another question. Yeah.
Okay. Sorry, we'll come to that later.
Yeah. So Stanley, you know the Synthex trial that you presented. I think most of the studies were done quite long ago. So we were using first generation drug-eluting stents, and I think today we are using third generation drug-eluting stent with a lot of difference. So we probably don't know whether the contemporary PCI is really that inferior. Do you have any comments?
Yes. So again, the data is what we have. So the Synthex trial is still by far the biggest triple vessel disease stent versus bypass trial, and we don't have very good studies thereafter. The best trial with the Korean trial would try to reproduce the same kind of study design with more contemporary stents, but again, we don't have definitive data thereafter. So although from an interventional cardiologist point of view, we'll say that yes, our stents are better, our techniques are better, we are achieving more complete total revascularization now. But the surgeons will also come to you and say that they have improved their techniques, they have on palm, off palm, and variety of modern techniques that will increase the longevity of their grafts. So unless we have a contemporary trial comparing the most modern practices, it will be biased either way to say whichever is better.
Thank you.
Okay, so now I understand that we have the GPs are the main attendees of this talk. So they will be following up the patient after you have put stents in them. So therefore it leads to the question of antiplatelet, because they may well be the doctor who's looking after the patient and advising the patient about antiplatelets. So with the new generation stents, how long would you advise the GP to continue dual antiplatelet, and which are the dual antiplatelet that they should give to their patients?
Okay, so for most stents at this point, I think according to our current guidelines, if you should be on minimum of 6 months of dual antiplatelet therapy, and it will be aspirin and clopidogrel. Unless you have an acute myocardial infarction, then you would be on a more potent medication. But for the stable coronary disease, it will be aspirin and Plavix for a minimum of 6 months. Some guidelines, some countries will say up to a year, but usually we'll say 6 months would be satisfactory. And thereafter, you can just remain on single antiplatelet, and of which either aspirin or clopidogrel, depending on your choice and depending on your tolerance. So hopefully after the cardiologists have dealt with the acute setting, and once they come back to you, follow up, let's say after 6 months, they should be back to the single antiplatelet lifelong.
What happens if the patient needs to go for some kind of surgery, like dental treatment or some kind of surgery? What is the shortest period of dual antiplatelet they must have?
Now, so in clinical studies, usually now we can go as low as, depending on complexity of disease, I would say between 30 days to 90 days. 90 days, I would say very safe. There are some contemporary data where if you just have a dual antiplatelet therapy for 30 days, it should be reasonable to interrupt it for a short period of time for surgery. So I would say as short as 1 month. And certainly we have sent many patients for urgent surgery, or let's say necessary surgery within 1 to 2 months after a PCI procedure.
All right, thank you.
Stanley, I have another question since we're on the topic of antiplatelets. Conventionally, previously, when we only have aspirin and clopidogrel and we don't have anything else, and someone comes to us and say, hey, I want to do a stent, but I'm allergic to aspirin, more than often not, we will actually refer them to our surgeons and say, maybe it's safer for you to do a bypass. But today, we have a lot more other drugs. For example, Brilinta, we have practised, we even have anticoagulants and NOAC. So I think, what do you think? If today someone comes to us and say, hey, I've got aspirin allergy documented, and but I've got a very straightforward single vessel disease, not complex, very low syntax score risk, will we consider angioplasty as an option, or should we offer him bypass?
Okay, a lot of the aspirin allergy actually nowadays, if necessary, of course, dual antiplatelet is still preferred, and we can even actually attempt aspirin desensitization. So a lot of government hospitals have a very good desensitization program. You admit the patients, trial them on different escalating doses of aspirin, and then you can find that actually patients do tolerate that. Okay, so where possible, give them an aspirin. Again, although we have also done procedures on a lot of patients on single antiplatelet, maybe as you say, Brilinta or ticagrelor or clopidogrel, that is a bit off-label, but yes. But I think since we know that the more potent antiplatelet like ticagrelor and practised, they tend to have a more effective antiplatelet action. So it does give some of us some confidence that maybe remaining on a single agent may be almost as good. But again, this is a bit of off-label kind of advice.
Thank you.
You see, Stanley, the problem is your talk was too short. So as a result, we end up having to ask you many questions and really tax you a bit. So you only have yourself to blame. So now, to that end, again, it could be a scenario where the GP is involved. So here's a patient stented, but he's now having atrial fibrillation. Or he may even have a patient who's having atrial fibrillation who needs to go for stenting. So how would you advise the doctor on his antiplatelet or anticoagulation therapy?
Okay, so say again. So if someone has atrial fibrillation and
needs stenting, right? So do you put dual antiplatelet plus warfarin or dual antiplatelet plus one of those novel oral anticoagulant? Which one would you choose?
Yeah. Again, hopefully this patient has already been managed by a cardiologist, so hopefully they will be able to proceed with the titration of the antiplatelet. But typically, at this point, I'll follow the European Society's guidelines. And currently, because if they have atrial fibrillation, obviously they should be on a NOAC, maybe your revascularization or dabigatran. Now, after stenting, of course, if you need aspirin and clopidogrel. So if you take all three, unfortunately, the risk of hemorrhage and risk of bleeding is very, very high. So at this point, for the uncomplicated patients, we'll usually give all three, maybe just for 1 month. So for the first month, aspirin, clopidogrel, as well as revascularization or dabigatran or Eliquis. Thereafter, I'll take off the aspirin, and then we'll stick on the clopidogrel and the NOAC for at least the next up to 6 months, the next 5 months up to 6 months. And then thereafter, depending on this complexity, you can extend it to 1 year, or you may just stop the antiplatelet. Beyond 1 year, we accept that patients have stable coronary artery disease. The stent is fully endothelialized, it's no longer an issue, then we'll remove that antiplatelet.
So simply put, it's better that these decisions be made by a cardiologist and a GP. Yes. But it does help when the GP advises the patient.
Yes. And again, unfortunately, there's a constantly evolving advice in this group of patients. And you can see that various societies have not really come to a clear, so the Europeans and the American advisors are all a bit different, but essentially this is a practice that we adopt. So we try to minimize the exposure to triple therapy, because although it's good and effective, but the risk of bleeding is significantly higher. And we are not also unsure, especially in our Asians, small size population, will we be at a much higher risk of hemorrhage. So that is certainly a bleeding risk that we have to weigh up against the ischemic risk.
I mean, as a electrophysiologist, I think the guidelines this year in ESC, they have come up with 2020 AF guidelines. So there is a very, very nice paper which actually summarizes the anticoagulation regime in the stable CAD versus the ACS patient. I think, Stanley, you're right. So triple therapy, maybe for the shortest possible duration, and then followed by dual therapy, and then subsequently maybe a single therapy. So that is the way to reduce risk of bleeding, because at the end of the day, most of our stroke AF patients who have high stroke risk on the CHEST-VAD score will also have a high bleeding risk on the HESBLED score. So you're going to have one high risk patient for stroke and equally high risk patient for bleed. So I think we have to juggle that a little bit. Okay, coming back to our talk today, since we don't want to digress too much to EP, for all left main diseases, is it a recommendation that everyone should see a surgeon first and discuss the option of bypass before we even consider putting in a stent for them?
Yeah. Well, I'll say in the ideal world, you will get all the opinions you like and speak to your surgeon, speak to your cardiologist, speak to an interventional cardiologist. But it's also very often then patients will say, why waste my time if I've already decided? But yes, in the ideal setting, yes, a discussion should be made or at least offered to patients. So at least they do hear the different views. The current European Society guidelines do still place PCI as an option for that's just as good as CABG for patients who are not highly complex. So let's say the low intermediate score. Whether this will change because of all the noise made by the cardiac surgeons regarding the Excel study, which I alluded to earlier on. But my feeling is still that these are still two very good options. Even if you have an absolute difference in mortality or risk of future MI, you're not going to talk about double, triple, quadruple. You're saying maybe 5% more here, 5% less there. But since these are two very different mortality, open heart surgery versus kind of 1 hour procedure, one night stay, I think patients do have to be given the option to consider this, as long as they recognize and the cardiologist will be upfront in terms of the potential future risk of a slightly higher risk of maybe MI or mortality. As long as they're comfortable with that and is well explained, I think I usually have no issues or problems with proceeding to performing a left main PCI for our patients.
Okay, I think we have thrown a lot of questions at you. I don't see any more questions coming from attendee. I don't. Jeremy, do you have any more taxing question that you can ask Stanley?
No, I mean, I probably just maybe share a case where I think Stanley also assisted me some years back. We had a young patient. So this is probably also quite relevant for young patients. Anyone who's under the age of 50 years old. He saw me as probably a seventh opinion, So he has seen a lot of very prominent specialists, cardiologists in the public sector, in the private sector. Every single one of them asked him to go for bypass. He's non-diabetic, heavy smoker, about 45 years old, with severe triple vessel. I think the reason he went for a bypass, he was offered a bypass is because he has multi-vessel and diffuse, so he will need a lot of stents. So I think almost everyone told him that he should go for a bypass. So he came to see me, and I also told him that he should go for bypass. So the seventh opinion is not very different from the first six opinion. But I think today's patients, I think we need to recognize that they are also very, very knowledgeable. They will come to you with things that they have read on the internet, and these are not blogs, these are medical information. So at that time, one of the device company had a novel technology called a bioabsorbable vascular scaffold. And he came and said, can I do this? Can I put in 7, 6 of these stents and instead of going for bypass, because he was concerned about everything that Stanley has mentioned. So after discussion with the patient and discussed with Stanley, I said, if you really adamantly don't want a bypass, the truth is, one day, even if he had acute coronary syndrome and he goes in with an acute AMI, someone will put in the stent for him. So what are your thoughts, Stanley? I think we did this case some years back. I haven't seen the patient for a while. He's been well. He has always been coming back to collect medication, but he's probably very fearful to come back to repeat another coronary evaluation. I think he has been past 5 years and he's still collecting medications from us, seeing me once a year. But he did relatively well for the last 5 years without any repeat revascularization using, I think we put in 7 BVS, in that patient. He was one of our record patients.
Now, I think it's good to emphasize to all our audiences that we always read the headlines about higher risk for PCI, whatever, how many deaths rate. But ultimately, when it comes down to a patient, as you said, I'll give you all the numbers, say double the, let's say if I send a patient for bypass, it doesn't mean that you get a stroke. I'll say you have a 1% risk of stroke, 2% risk. That risk is actually quite low. Same as PCI for multi-vessels, maybe with the absorbable stent, or even with a drug-induced stent. Your risk of needing a second procedure after 5 years is, let's say, 20%. So in other words, 4 out of 80% of patients will do perfectly well with absolutely no problem, no events, and they live a long and happy life after the procedure. So for the individual person, although sometimes it's down to your absolute risk, your risk may not be that high. It's just that when you look at the broad picture from a, let's say, a society perspective or economic perspective, if I send so many patients for stenting, then yes, you have to end up paying for a few more revascularization. But down to individual, as you say, for this patient who have many, many stents, the risk of you say, oh, yes, it's high, but how high is high? Maybe 10%, 15%, 20%. In other words, 70% of the time he'll get away without any problems, and he'll thank you for a very simple life with no major downtime, with no major complication. So I think there's a way to interpret clinical trials where we want to adopt all the statistically significant results into the guidelines, and they have to be written and fashioned in that way. But when we try to interpret all these results for our patients, we have to adopt a more personal view or basic holistic view, and what is it really meaningful for an individual person? Because a patient doesn't care about there's a 5% risk, 10% risk, they just know what will happen to them ultimately. And I think when we explain to them in those terms, hopefully they can understand and make a more sensible decision for their own health.
Okay, thank you. I think Chong Hyo, we probably can sum up.
Yeah, okay. So thank you, Stanley, for being so brave in answering our challenging questions. I think the take-home message today is that with coronary artery disease being so common and both modality of treatment, whether it's bypass or stenting, it's so accessible in Singapore. It's not like a third world country or whatever. You can get whatever you want. The problem is the choice. So that the dogmatic people will say, okay, you have left main or triple vessel, you must go for bypass. Or if you have single vessel disease, you must go for stenting. I think the technology and what the general public knows now is so great that really I think they are well informed to make their own choice. So it is truly our job to explain to them the pros and cons of each procedure. Bypass is not once and for all, because once your grafts are blocked up, it is very difficult to treat you because very high risk second bypass procedure. Whereas stenting is very simple. You go through the same low risk procedure. You may have to go for more than one time if you go for stenting, but it's certainly easier than opening you up a second time. And it's not all coronary diseases are the same. They may have simple triple vessel disease where the 3 vessel blockages are very discrete and it takes no more than 45 minutes to open up all 3 vessels, or they may have very long blockages. So it's not whether you have or you don't have kind of condition. So I think with all these in mind, we really need to spend more time talking to the patients, and so that they can understand their own condition and come to a well-informed decision. I think that would be an important lesson we learned today. Okay, so is there any additional comment, Jeremy?
No, I think we're all good. Anyway, time.
Okay, fine. So we can end this session. Thank you, all of you, and thank you, everyone who attended this session. I hope it's been beneficial to all of you. Have a good afternoon. Goodbye.